Dear Pure Urology Facebook viewers, uh, good evening one and all. Today our topic is interesting topic. Like any urology, stone is the bread and butter, and we all practice stone surgery, especially in Indian subcontinent, where mini perk has come a long way in the stone management. Even though definition of mini perk is not defined, some say 12, some say 15, some say 18 also. There is no scope which is 15 French alone scope, so that 15 by 18 is maybe ideal. But because we have 18, we will go 18 by 20. We have 12, we will go 12 by 15. Irrespective of this nomenclature, our idea is that large stone volume, usually I put 30 French dilatation if the puncture is good, because breaking stones and taking it out is a tedious job. But science does not accept that you have to go less than 20 or 22 French or 18 French like that and then do the surgery. That is the topic today, mini perk and staghorn calculi management. To be honest, the speaker is Dr. Kamlesh Kumar Maurya. I came to know about him recently. I went to his hospital, Mark Hospital in Bilaspur, Chhattisgarh, where we have done a live workshop. Extraordinary facilities. The theater is built according to the science, according to NABH rules, and we surgeons, approximately 8 to 10 surgeons, have operated in 3 theaters with live transmission of 21 cases a few months before at Mark Hospital, Bilaspur. So thank you, Kamlesh Kumar, for accepting the invitation. Hi, good evening.
Hi, good evening, sir.
Yeah. So Kamlesh, where did you do your MBBS?
Sir, I did my MBBS and MS from Riva Medical College.
Riva Medical College,
That's in Madhya Pradesh.
Madhya Pradesh.
Yeah.
And how did you develop interest in urology? What made you to take urology? Because it is easily practicable, or you had some mentor who influenced in MS?
So, sir, not in the MS, because when I did my MS, there was no urology department in my hospital.
Okay.
So when I was working as a senior resident in Delhi, so I used to see a lot of urologists. They used to do a lot of endoscopic work, and that fascinated me to go into urology.
Where is your native place?
I am from Riva only, sir.
Riva is in Madhya Pradesh, and you are
Sir.
in Bilaspur. How
Yeah,
come you
now it
got
is.
Bilaspur?
Because when I was working in a mission hospital near Bilaspur, so Apollo Hospital came in Bilaspur. So I came to join Apollo Hospital, and then slowly after that I went for my DNB urology.
Very good.
I did my DNB urology from Amrita Institute of Medical Sciences, Kochi.
Okay. That's
My
a
mentor
famous.
was Dr. Sanjay Bhatt.
Yeah, very good. Very nice. So that is nice to know. So with this, I will introduce you officially, and then I will hand over the program on this topic. So, dear friends, today's session on pure urology FB forum is mini PCNL in staghorn calculus. How I do it. Dr. Kamlesh Kumar Maurya. And Dr. Kamlesh is consultant urologist and director Mark Hospital, Bilaspur, Chhattisgarh. Part of renal transplant team at Apollo Hospital, Bilaspur, performing lab donor nephrectomy. Co-investigator in many clinical trial projects. Laparoscopic urology, endourology, and reconstruct his interest. More than 25 papers presented in various conferences. He has many international and national publications. Organized many workshops under the aegis of West Zone and Chhattisgarh Urology Society, where I was also part of the one workshop at that is hospital. And even in the Chhattisgarh, when the conference conducts, he comes there, he meets people, and he actively involves in conferences conducted at Chhattisgarh, Raipur also. Many times I have been to Raipur with local seniors, he goes. So I am very happy that my close friend Junior Kamlesh is giving the mini perk and staghorn calculus. Over to you, Kamlesh.
Thank you very much, sir.
Yeah, you can share the screen.
Yes, sir. First of all, I would like to thank
Yes.
Chandramohan sir for giving me an opportunity to be a part of this pure urology group which has taken the teaching by storms. And now we can see a lot of videos. And whenever we are in a problem, I always go back to the pure urology and see what has been discussed earlier to find the solution for our current problems. So today I'm discussing about mini PCNLs in the staghorn calculus, how I do it. I started doing mini PCNLs almost around 8-9 years back. I saw Dr. Sanjay Khadge operating in a Parcon and was very fascinated with his straw and mini PCNL. So I went there, learned the tricks of mini PCNL. And since then, I have left all standard PCNLs. I'm doing only mini PCNLs, whatever the size of the stone may be. So 7-8 years when I was discussing with others and telling them that I do mini PCNL for staghorns, but nobody was believing it. Everybody was saying it's very difficult to do a staghorn PCNL by a mini. But I think now most of people are doing it, and they realize that this is possible and can be done. Of course, for everything we have to be judicious and take our call depending upon the case-to-case basis. So as we all know, PCNL is a standard therapy for treatment of the renal calculus, and getting a access to PCNL puncture, that is the most important. Staghorn calculus is defined as a stone in renal pelvis extending into the 2 or more calyces. It can be complete or partial. So aim of the surgery in PCNL, whatever it's normal or a staghorn, is to have a complete clearance of the stone. And it may require a sandwich therapy. Earlier, we used to do a PCNL, lithotripsy, then PCNL for complete clearance. But now, with the advent of new scopes, new technology, and new teaching methods, and particularly the laser machines, most of the time we are able to get away in a single stage. And if there are any residual fragments which can be tackled later on by an RIRS also. But what is the problem with the staghorn calculus? It is basically a large volume of a stone, which is the problem. So it takes time to break the stone and take it out. But what I feel is the breaking the stone and taking out depends upon your experience, expertise, and the method of doing it. And secondly, it may require multiple punctures. So there are always chances of residual fragments. And most of these stones may be associated with infections. So we have to clear the infection prior to surgery. So getting a urine culture is a must for all staghorn calculus. Even if we have a negative urine culture, still we can have infection in the pelvis. So we have to keep that in mind. And we might have to stage the procedure by bleeding, infection, or if there is a large bulk of the stone and anesthetist is suggesting to stage it, we stage the procedure. So consents, apart from taking a general PCNL consent, I always take for a stage procedure for residual fragments and blood transfusion. Normally, I don't do a blood transfusion for all my patients. We do keep reserve blood. We ask them to get a blood grouping, and if there is any rare group, we discuss with the blood bank and ask them to keep a bottle of blood ready so that in case if needed. But fortunately, we usually don't require this. Most feared complication of PCNL is the bleeding, and that's where the size of the tract started mattering, and people migrated from a standard PCNL to a small size PCNL. So, and most of the studies have also shown that a small size tract decreases the blood loss. Classification of the PCNL, as Chanmohan sir has said, it's not exactly defined, but most of the books what they quote mini PCNL is anything between 14 to 22 French. What I normally use is a 20 French size amplas for most of my patients. In children, I do use 16 or 18 amplas, or some cases with small stone, I go for 18. The reason for choosing 20 was that the 16 amplas sheath is very soft, and it's in one case it gets, so 1 or 2 cases it gets bad in shape. And 20 gives ample flow of water along with the scope, and most of the stones we don't have to pick up, they just pass out along with that. So for any PCNL, particularly in staghorn calculus, we had to preoperatively plan the case, and I'll discuss in operative planning and post-operative management what I do. Initial planning, most of the patients in my stage, we do a IVP, and if the patient has a high creatinine, then only I go for CT scan. Nothing wrong in getting a CT scan. Only thing is that I am well versed with the IVP, and I feel that planning a puncture in IVP is much better than a CT scan. Probably that is because of my learning period. And the problem is always where to puncture. So proper puncture planning is the key to successful surgery and outcome of the PCNL. So we have to puncture in a place where we can clear major bulk of the stone. And secondary punctures also we can plan initially. In the initial days of my learning, I used to put a guide wire in all the calyces and puncture one calyx, then complete the stone, and then go for the other puncture. But over a period of learning, I realized that many of the times we don't require those punctures and that guide wires which are hanging inside. That creates a problem also. So now I do just one puncture initially, and whenever is needed, I can do a stone guided puncture. So this is, you can see it's a stone. So once you puncture and get a fluid like this, so we don't need anything else. We can just proceed. One more thing, and if you're inside and if you move your needle sideways, and if you see the needle is within the confines of the pelvic health system, most of the time you are in the system. So planning, if you see this is a bigger stone, so what happens is if I go through its lower callus, I'm able to get most of the stone, only the calluses which are there. These stones may be difficult to get. But once you clear the lower calyceal stone, it's a wide infundibulum, and our narrow scopes can go up and clear most of the stones with a single puncture. This is straightforward. We can go for a lower calyceal puncture or upper calyceal puncture. Only problem is, in this case, I preferably avoid to go for upper calyceal puncture with the fear of getting into the supracostal and causing pleural injury. So most of the time, I prefer to remain either in the subcostal or between 11th and 12th rib only. Like in this stone, it's a staghorn calculus, but if you puncture through this calyx, lower calyx, you'll be able to get most of the stones. Like this, if see, once you see the X-ray, it looks like a very big stone and very difficult to do. But once you go to RGP and IVP, you can see it's a very dilated system. Sometimes what happens in the IVP in these type of the cases, this dilated calyces are not properly visualized. But once you do an RGP, you can better see them. And if you have a dilated space, then probably your instruments can always move around and we can completely clear the picture.
Yes.
This stone, this has the callus, stones in all the calyces. So I went through this puncture, completely cleared. Then one stone was remaining, which is almost perpendicular, very difficult to get into this thing. So we had to make a second puncture. And if you're going for a second puncture, better is always to go for a smaller size amplas. You can go for a 16 or 18 because the bulk of the stone is very less. And many times what happens is once you dilate, this stone migrates into the pelvis.
Kamlesh, do you believe in pushing the stone with saline or pushing the stone with alkane or pushing before dilating? Do you try like that?
Yes, sir. I do two things. Once I puncture and try to push the stone, many times the stone goes into into the pelvis. So we can just pick it up. Second thing, what I do is I do a puncture and place the guide wire. So if the angle is not very acute, sometimes what happens, the opening is very narrow and we are not able to get through that opening. We are not able to trace it. So once you place the guide wire, you can move your instrument into that calyx and remove the stone.
So you will come
That,
back to original nephrostomy tract and then search along with the guide wire, and sometimes you may get it. You mean to say?
yeah, yes, sir.
Okay.
That way we can
So
avoid one more puncture.
you pass a guide wire search, you flush with water, and you push it. These are the various methods. If the infundibulum is large, you can get it, so that you need not dilate.
Yeah, yes, sir.
Very good. This case is a very good case, but I personally feel RIRS, CCIRS, supine PCNL will help a lot in such cases.
Yes, sir. With your inspiration, we are trying to learn RIRS.
Yeah.
Probably I'll also start doing ECIRS.
Very good case for supine PCNL, and but you have cleared. I am surprised. Your magic hands in going from the arrow mark green and the main stones are easy, but upper calyx, the other calyx are all. In this case, was it dilated system?
Sir, usually these people have little dilated system.
Yes.
I will discuss also in the later period of my talk that sometimes when you have a peripheral calyces, actually we don't need to go into the calyx. Still we can remove the stone.
Yeah. Okay. Show me.
So this is a straightforward. Stone looks very big, but such a dilated lower calyceal system with the pelvic stone, we can puncture and remove all the stones. So what is the problem with the puncture? There is no space in the calyx. It's very difficult to negotiate guide wire many a times. We can puncture it, but we are not able to place the guide wire. So simultaneously, if we put saline through the ureteric catheter, sometimes the guide wire can pass. Secondly, is we can use a new thermo guide wire, which is very slippery. It goes into the ureter or any of the calyces. And if you can park significant amount of guide wire, then we can dilate. And once you put your initial dilatation, you can always switch over to the old Teramo or a Zebra guide wire, which doesn't slips out. And secondly, you push into the needle into the stone, then withdraw just a few millimeters and then try to pass a guide wire, you're able to pass. Secondly, you may not be able to put implants inside the pelvic calcium system because there is no stone, there is no space. In those cases, we have to keep into the parenchyma with the mucosa, which can be seen. And then with the help of the laser, I make out a space and then we park our implants into that space. I do almost all my cases under anesthesia, spinal anesthesia. General anesthesia is only when spinal anesthesia is contraindicated. And to increase the time of anesthesia, my anesthetist adds on to butyrophenol or clonidine to spinal. That increases the time. I mostly do prone PCNLs. Supine PCNLs, with your seeing videos, I have started, but I am only doing for a small case stones, not for staghorns. And I don't keep bolsters because I feel if you don't keep the bolsters, kidneys are more firm and puncture and dilatation is easier.
Even I don't put bolsters. I never felt anesthetist is in trouble. My anesthetist is used to it. He never felt respiratory distress. What about you?
No, sir, I never felt like that. Only in obese cases that I do keep because my anesthetist is not happy with that cases.
Yeah.
Otherwise, routinely I don't put.
Okay.
And I am doing all my punctures in the monoclonal technique, keeping the keeping the CM in the 0 degree. And almost the descending flight technique, which I learned from SK Paul sir. Although he is doing in 30 degree, I do in the 0 degree. And very rarely I need to change the direction of CM.
Yes.
Initial dilatation is with the facial dilators. Then I do a single step dilatation. I keep the central rod of the alkans and then over that dilate and put a 20 French implants. Initially, I was using a Wolf short ureteroscope, which is 9.5, 11.5, and I was very comfortable with that. But now company has stopped it because this I learned from Dr. Sanjay Khadgi sir, and now I'm using mini perk from his stores. For fragmentation, I'm using always laser because I feel laser makes into a small fragments, which avoids the stone fragment retrieval time, and stone doesn't migrate to different calyces, and we don't have to chase them. Causes less bleeding because once you do use a pneumatic, what happens is the back wall of the pelvis is also getting hit. So many times that starts bleeding. So in laser, we can avoid that. And I do use a pneumatic for a larger stone because once you make a hollow in the center with the help of the laser, then it becomes like a egg shell. And you use pneumatic, it becomes very fast.
Very correct.
And this is like a big stone. In this case, puncture is straightforward. You don't have to worry much about that thing. Only time is to take out this stone through a 20 French implants. So I make a hollow, all the center hollow, and then use pneumatic, break the stone. It becomes very fast, and you can clear the stone. And this is what I do is I'll try to make a hollow in the center, then go to the periphery. And once you go to the periphery and start breaking with the laser, it causes fragmentation of the stone. So you don't have to pick up. And most of the fragments are small in size, they get just washed off with the help of water. And once you start hitting in the lateral part, it will break into pieces only. And once you have made a hollow, I'll just come back. Yeah. So this is, then again we start using pneumatic.
Yeah. This is a combination. What you told directly, if you use pneumatic, it won't hit in properly in the round surface.
Yeah, and then sir, the problem is again the stone gets migrated. Now it is we have already made a hole in that, so it becomes very fragile.
Correct.
It breaks very easily.
Basically, the structure is weakened.
Yeah, yes, sir.
And then you are breaking. This is very valid point, extraordinary point.
So the other problem with the staghorn calculus is the main bulk we can always tackle with any of the punctures. The problem is in the peripheral stones, which are in the different calyces. So what I do is after removing the main bulk, you keep your scope near the calyx opening, and usually we are able to see the stone and then break the stone by laser a bit by bit. So what happens with the flow of the water, the stone just tries to comes down, and once it comes down, you just break the stone and you will be able to clear the stone. And other thing is that you don't need to put amplas till that part. You can keep the amplas in the calyx which you have punctured and little away from the calyx you want to enter. So in that cases, because our scope is small size, the torque on the calyxal angle is not too much, and we are able to maneuver into that calyx. Like sir, in this case, you see this is a stone. We can always clear this bulk. Only problem is with this stone in the middle
Yes,
calyx
yes.
or upper calyx.
Yeah.
So what happens is this is a video in which I have cleared all the pelvic stone, and there is a stone in the upper calyx. This is the middle calyxal puncture. So
Yeah.
I am not able to go into the upper calyx, but you can see, and once the stone with the water flow, stone just descends down.
Yeah.
So then you start breaking with the laser, and in that also because the stone is big, so there is not much point in going into the middle part. What you go into the periphery, lateral side, the stone size becomes less, and it starts migrating into the pelvis.
Valid point. It becomes floating and then space will come. It will
Yeah,
drop
yeah.
down. All that measures if fail only. Do you think that external compression by hand over the chest also sometimes no?
I have not tried, sir, actually.
Very
We'll
rarely
see
it
the
helps.
next case, sir. Because this the stone was looking very big. It becomes small and it just comes along with the flow of the water.
Very well.
I just want to share this one experience which recently I did. It was a big stone. The patient had a history of passing stone for last 10 years, but he never got his worked up. So this was the stone. So I had to do an URS for the lower stone. Upper uretary stone I pushed into the kidney and then did a puncture. So you can see the calyx, all the calyces are occupied by the stone. So I did a lower calyceal puncture. So I could clear all at this part. Only problem is this part of the upper calyceal which is dilated and has the secondary stones. And this is the middle calyx. So you can't go into the middle calyx with this angle. So I used a
Yeah.
nephroscope. Unfortunately, my this actual video got lost. So this is the upper calyx you can see. So I don't have to break the stone. Just we went there, put the scope, flush water, and most of the stones can come down. Few
Yeah.
stones required laser and which we can break. And similarly, you can see the middle calyx also. Because the opening was narrow, if I could go through this, and the most of the stones came out. Some I had to do a laser.
Yeah. Ultimately, how many punctures in that case?
Only one, sir.
Show back. Show back. You have cleared all the stones with one.
Yeah, I have not put the poster picture actually, sir. I'll
Okay.
share in the group because I just wanted to demonstrate that how this flexible nephroscope can also help in a system which is very dilated. Because
Very good.
normally the system is not dilated, we are not able to move around with the flexible scope. But in this, the system was very much dilated, so I could go all around and do this.
So you should see in such a way that large volume stone can be removed through puncture. That is the aim of first puncture.
Yeah, so almost all the stone I could remove with this
Yeah,
single
yeah.
puncture only.
So with that middle calicial stones also have come out. Very lucky, very happy, and very technically good job.
So, but this is one staghorn calculus in which I made a puncture through this calyx. I could remove every stone through this. This angle looks very acute, but once you go inside and dilate and see, you always can move into this lower part of the calyx. So this stone was remaining, so I had to do a second puncture and dilate the tract and take it out.
Very good.
This is a soft stone, so wherever you puncture, most of the time, just with the flush of the water, it can come out.
Yeah.
These are the stones which can be dealt with either lap also. The only problem with this is the bulk is stone in the lying in the pelvis and the infundulum is very narrow. But with the 20 French amplas, most of the infundulum can accommodate. We can go inside, break the stone. Again, I use both dual energy laser and pneumatic to break the stone.
Very good.
This is one case which I would like to discuss. This was a staghorn calculus, which I did recently. I passed the guide wire, punctured it. I couldn't get the fluid. I thought it is because of packed stone. I am not able to get the fluid. So I dilated, and this whole guide wire was going just outside the mucosa.
Oh my God.
So
You could not see the stone?
no, sir, I couldn't see the stone. I'll just show you. This is I'm in the parenchyma, but luckily it was not bleeding much, not at all actually. So this is the mucosa which was there, and this whole because of the guide wire, this parenchyma was lifted away from the mucosa.
You could not go into the system.
No, sir, not with the puncture. Then what I did was I just make a cut with the laser.
Oh, that is risky because we don't know no, where we are.
Yes, sir, but with the CM, I was able to see that I was in the calyceal part only.
Oh,
So I just made a cut with the laser. I tried initially a little bit, then I could cut that part. And now you can see the stone.
okay.
But still, I'm in the parenchyma only, so I have to make little more space
Yeah.
to go into that thing.
In case of large stone, if the contrast is not coming, do you feel with the needle the periphery of the stone and then directly pass the guide wire?
Yeah, that's what I normally do, sir. In this case, I felt I am in the system.
In that case, if the guide wire doesn't go, what are the tips and tricks?
So then probably we have to change to the other calyces because till the guide wire is in place, it's very difficult to dilate blindly, and we cannot dilate also. So
But I do
then,
a little bit of saline, forcibly 2 ml, 10 ml, 5 ml you inject and then pass a guide wire. Sometimes it gives space over the stone and goes. That
yes,
is
sir.
one option. Second thing is pass only few centimeters of guide wire over the stone and then first dilator like alkane rod. You dilate and then keep on the stone alkane rod. Rest of the dilatation is over the alkane rod.
Yes, sir. That's what normally we do, but
But
sometimes
in
still we are not
that
able to
case,
get
you
that.
show me the previous case that is densely impacted. That's why guide wire. Show me previous slide. Previous slide.
Yes.
This stone is totally impacted up to the periphery of the calyx. So sometimes guide wire may not go. So you may have to dilate small amount of guide wire over the stone. It is
The other
difficult.
option was to go through the upper calyx because upper calyx was not having the stone. It was
Okay.
dilated. But if you see, sir, this is we would have to go through the second means 10th and 11th rib.
That is very high.
It's very high. So I thought I will just try through that, and I was lucky to get into that.
Very good.
So this is the stone I could see, and once we made a space, then I passed my the amplage into the system, and this I could break the stone completely. So,
Yes.
and this is one incidence which you were telling, sir, by forcing saline. So this was the upper calyceal stone. My over enthusiastic assistant was pushing contrast, and suddenly we saw the extravasation of dye. So this also happens sometimes. So we have to be cautious that our saline push or this should not be very under pressure. So this is what I want to show what happened next. Once we cleared the stone, then we saw just with the help of contrast, this whole mucosa was torn. So I'll just repeat this. This is the ureter, and this injury you can see in the mucosa, sir. This was just because of contrast push. So we have to take care that we don't push contrast too much. And I don't put a PCN tube, sir. Initially, when I was in 30 French implants, I was putting it. But with the mini pistons, slowly, I think last 5-6 years, I have started putting PCNL, so PCN. And initially, when 30 French implants I was using, many cases had a urinary leak also, few cases. But now I rarely see those. Only if there is significant bleeding or I'm planning for a stage procedure or infection, I do it. I do put a degestant in all patients, which remove 2 to 3 weeks, and I give for long-term antibiotics for recurrence and preventing infections. Residual fragments, of course, I'm not able to clear in all cases, but earlier I used to give lithotripsy, but now we are able to clear most of the stones by RIRS. So our clearance rate has become little high. Although the staghorn calculus PCNL is technically demanding, maybe time consuming, sometimes it becomes very difficult. It can be challenging also, but we have to do a careful preoperative workup. Intraoperative assessment is also required, when to stop, when not to stop, how far to go. It may require multiple punctures. But along with all the gadgets, what I feel is the most important is the surgeon's experience for a successful PCNL, whether it's a staghorn or a normal, but it is feasible and well tolerated by patients. So we are doing almost, sir, in a month 4 to 5 staghorns at least, and I'm doing all with 20 French emperors only, sir. So that finishes my talk, sir.
Very good. Quite a large volume of stones you have in your place.
Sir, we are doing almost around 30 PCNLs in a month.
Fantastic. Very high volume, and I think you should keep posting in our Pure and social media also, so that people can learn without revealing the identity of the patient. Now, quick fire questions I will ask 10-15 questions.
Yeah, sure.
Number one, what is your favorite guide wire in difficult situations? Is it Termo or Zebra?
Sir, I usually use Teramo,
Termo.
not the new one. I use initially I try to use Teramo, which has been used few times. Then, if it is not succeeding, then only I go for a new one.
New one. Number two, ureteric catheter size you use in all these cases? 4, 5, 6.
5, sir. 5 or 6.
5 or 6. Have you ever used ureteric catheter with multiple holes for flushing?
Yes, sir. I used it. I tried that thing, but I thought that doesn't give much of the advantage. That's my perception. So I stopped doing that, sir.
Okay. During initial part, your dilatation technique is single step or multiple step serial dilatation?
Sir, initially when I started with PCN, I was doing a serial dilatation, but now I do a single step dilatation.
Single step means first you
So
pass the
initially
guide
means
wire.
I will do a facial dilators. I'll use
Facial
a facial.
dilatation up to 12 French.
Yeah, sir. Then I put a central rod.
After that, what will you push directly?
I push the central rod, the metal rod that is there, and over that just dilator, sir.
Central rod is Alken rod, no?
Yeah, Alken rod. Then over that we do put a Teflon dilator, and then over that plastic.
Okay. Okay. Usually, which pneumatic lithotripter you use? Company, any specification is there?
Sir, I was using Nidhi.
Okay. Any other you recommend?
Sir, I have not used any else, so
Yeah,
I can't say much.
Why you wanted to use laser in large stone? We have shown all these cases, now. You are mentioning that pneumatic can perforate, whereas laser also can perforate posteriorly if you don't properly see it. And laser fiber, what size you will use in lithotripsy of large stones?
Sir, I use a 550 microfiber.
What laser you are using?
I'm using Quanta laser, sir.
What is the watts?
Sir, initially I was using 30 watt, but recently I upgraded to 60 watts.
30 watts, what is your setting then? 1.5 and 10?
I usually keep, sir, around 1 and 12 or 15.
1 and 15?
12 or 15, sir.
12 or 15. Do you think that is sufficient for hard stones in stagger?
No, sir. Then depending upon if it is not fragmenting for very hard stone, then I have to change the setting to a higher side.
Normally, when you are anticipating multiple punctures, will you do all those punctures in the beginning only to pass the guide wires?
No, sir. Initially, I was doing that thing, but then I realized that many times we don't require that punctures. And secondly, what happens is that guide wires are lying within the pelvis, so that also creates sometimes problems in proper flushing out of the this thing. So, normally in all cases, now what I do is when I am securely placed into the system, I remove my guide wire also. So that becomes the flushing of stone becomes much easier.
What about if the ureteric catheter flushing does not show contrast going into the PCS, what will you do?
In a staghorn calculus, sir?
Any calculus, staghorn versus small stones. If you don't have ultrasound, what are the tips and tricks to delineate the PCS if the contrast is not going through the ureteric catheter?
Sir, most of the time, once you guide wire may not be going, guide wire and ureteric catheter.
Contrast is not going because of the impaction.
Then in those cases, sir, we can blindly puncture the renal angle with a fine needle, and most of the time you're able to get a free fluid, put some contrast in that cases. And once you get a contrast through that, then you can always puncture from whatever you want.
Do
Other option is
you
to go for ultrasound puncture.
do you believe posterior calyx puncture only in prone PCNL, or you can puncture any calyx which is lateral and accessible?
No, sir, I don't search for posterior calyx. I puncture whatever calyx I feel can directly lead me to the stone, and we can get there.
In superior and inferior calyces, if you have puncture possible for lateral
Sorry,
and
sir.
inferior, lateral and medial calyces are present, you prefer lateral or medial? You try to analyze any anterior posterior or directly go for lateral?
Sir, I have not analyzed much in that thing. What my aim is the dilated calyces where I can puncture and go directly to the stone. And I also see that if there are any secondary stones, then whether I'll be able to move into that calyx through that puncture or not. According to that, I decide. I don't
Okay.
bother too much about the posterior or anterior calyx.
Uh, if the stone clearance is not present, maximum how many punctures you have done in your practice?
I think four, sir.
Maximum dilatations.
Maximum dilatation is only 20 only, sir. And
No,
I'm
no, three tracks, two tracks, four tracks.
sir, initial puncture is 20.
No, no,
Maximum puncture
tracks, number of tracks, one,
that's what
two,
is it. Four tracks maximum I have done, sir.
four you have done. If the bleeding occurs, what is your mind says during staghorn? If the bleeding happening during the stone or suddenly during the puncture, I mean while mucosa, what will you do? Bleeding? How will you address bleeding? Bleeding.
Sir, then we have to see whether the patient is hemodynamically stable or not. If the patient is not getting hemodynamically stable, then better is to stage it. Second thing, what happens many times if you're working in one calyx and bleeding starts, and
Hmm.
if you have a stone in the other calyx and which is easily accessible, better is to leave that part, go to the other calyxes, operate the stone, and then come back to that calyxes. Many times by that time the bleeding stops. Along with that, I prefer ask my anesthetist to give tranexamic acid. So that also stops bleeding many times.
What scope which company you use? Mm, um, Wolf, George, Olympus, which microscope is good for purchase?
Sir, I am using screws and I'm happy with that, sir. And secondly, I have a short ureteroscope. I was using earlier with Wolf. Now I have endosis short ureteroscope. So what happens is many times if the difficult access, that's a small size. So we can go to the other calyces.
I was using recently 13.8 Shali. It is also good, honestly, because it's perfectly 6 for 16 French and 18 French, 17 French, whatever ample sheath you want to dilate, and it is true mini perk it will become. You need not go up to 22 French in a small volume stone. And what is the incidence of the generally you see post-op X-ray? Sometimes you may find residual calculi. Dr. Siddhalinga Swami is asking that what are your incidence of residual calculi in your experience? 10%, 5%, 20%,
Sir, it's less than 10%.
less than 10%.
One thing I
Sandeep,
would like to quote, sir, in that case,
yes,
what
yes.
happens is interpreting a Siam is also very important because I have seen many times what happens, there will be a small residual stone. And with the stone, we may be tired or something. Many people I see my colleagues to leave out that stone which they are not able to appreciate on Siam. But once
Yes.
in X-ray, you will see that there is a 5 mm, 6 mm stone lying there. So we
Yeah.
had to be carefully identifying the stone during my Siam examination, and also many stones lie behind the amplas. So we have to move the amplas in the different direction and see that whether we are completely cleared or not.
If you are using starch 18 French sheath, 22 French is better, 20 French is better dilatation.
Sir, normally I am using Cooks I was using, now I'm using Boston. I'm not using the dilators given by stores.
You prefer 22 dilatation or 20?
20, sir.
20. Sandeep is asking post-op sepsis management in spite of preoperative antibiotic. What was the coincidence of perinephric hematoma angioembulation in your cases?
So touch wood till now, I had no cases for angioembolization. There
Very good.
has been instances of post-operative bleeding, which are usually managed by tranexamic acid, and they settled. Secondly, sir, for post-operative sepsis, one thing is that we give a proper antibiotic at the start of the procedure, and if the suspicion of infection is there, I add on to amikacin, and my anesthetist gives a hydrocortisone dose in all those cases where the infection is suspected. So most of the time, we don't have a septicemia. Some people do get fever. In that cases, we have to upgrade to lupinam or miromac for higher antibiotic, and they all settle, sir.
Last question. You say that I don't put nephrostomy. In the post-operative period, if any ureteric stone, any dropped stone in the upper ureter gets struck, and then if the patient complains of high-grade fever and pain, what is the incidence of such things? I put nephrostomy always. You are putting never nephrostomy. When this will end, I feel there is no pain one day, next day morning you remove it. By the time a little bit of edema around the PUJ region decreases and you have comfortable draining of the kidney, whatever the infection contamination will come down is my feeling. And by putting around a 16 French small Foley's or the suction to cannula tube, not much pain to the patients, I feel. What is your take? Have you ever repented by not putting nephrostomy tube in last 3 years?
Not exactly, sir.
No.
No, sir. So what happens is the key is basically what I said. That we have
Kamlesh?
to examine CM very minutely at the end of the procedure, because most of the time we are able to see the fragments in the ureter and we are able to take it out. The
Do
advantage
you do
is that,
nephrostogram in such case? Do you do nephrostogram in such case?
no, sir.
No. So you will carefully see in the CM only. Which CM you are using?
I am using a Arranger CM, sir.
So that is reasonably good to identify small stones with your eyes.
Sir, actually, what I have seen is that in the CM the stones are visible, but we have to be focused to see where the stone is.
Yes.
Otherwise, you can always miss. Second thing is that the with short ureteroscope, which I was saying, endosys short ureteroscope, I was using wolf. You can go very well down into the ureter also, and if there is a stone fragment which is in the ureter, that can also be taken out. And most of the time, I prefer to go into the ureter and see if there is any fragments are lying there or not. Occasionally, it has happened that at the end of the procedure, I have seen that. Pardon, sir?
After you have done many cases, do you think that you have ever felt that RIRS is worth or totally useless?
No, sir, IRS is worth actually. Because of the logistics and financial aspect.
Because you are so good in puncture, you can remove 5 mm, 8 mm stones also. Then why RIRS then?
No, sir, when I do RIRS now, I have no fear of bleeding. I have done so many PCNLs, means I am doing almost 25 to 30 PCNLs per month. But still, every PCNL, I am little scared, because many times what happens, the PCNLs which looks out to be very straightforward, next day you will see the bleeding coming through them. So always I think if you can make without puncture, it's always better.
Yeah. So I feel small volume stones RIRS will still help, and large volume stones PCNL is good, and prone and supine no difference. And Dr. Kamlesh,
Yes, sir.
You have presented very well. To be honest, what is my feeling is that you have gifted hands. You know how to tackle the parenchyma, move from one calyx to other calyx. This is intrinsic ability. So many people will get. Once you get that ability, a PCNL becomes very easy. And you have shown nice cases. Thank you very much for your presentation.
Thank you very much, sir, for giving me this opportunity.
Very nice presentation. Very nice cases. And you have volume and experience. So keep sharing, and we will have more sessions with you every 6 months like this with more interesting cases. You can